Hello, everyone. Welcome to this year's 12th Anne Klibanski Visiting Lecture Series. My name is Jody Gilman. I'm the Director of the Graduate Student and Postdoc Division within the Center of Faculty Development. In today's session, Dr. Hanano Watanabe from Weill Cornell Medicine in New York will present on pediatric heart health, 4 high-impact topics for general pediatricians and pediatric cardiologists. We're so excited to have her here today. Let me tell you a brief history of the Anne Klibanski Visiting Scholar Award. It was created by the former CFD director, Miriam Burdella, to offer MGH women faculty the opportunity to serve as a virtual visiting professor and give grand rounds or other special lectures at a national or international institution organized by the Scholars Champion, a senior faculty member at MGH and the CFD. This program and the accompanying lecture series is named after Anne Klibanski. She is the president and CEO of Mass General Brigham and the former director of the Center for Faculty Development. A highly successful researcher with an amazing career, Dr. Klibanski has been a strong supporter and advocate for women. So this program began in 2020, and here is our original cohort of 36 scholars. And then our next cohort, 2021 to 2022, had 32 scholars. And finally, in 2022 to 2023, we had 31 scholars. Dr. Joanne Chu from this cohort is highlighted here, and she will be introducing today's speaker from Weill Cornell Medicine, the institution which hosted Dr. Chu's virtual talk as part of this program. Next slide, please. And finally, this year, our 4th year, we have selected 29 new scholars. You might recognize some of them. This program would not be successful without the commitment and energy of our Anne Klibanski Scholar Champions, who are helping this year's scholars find exciting speaking engagements. So thank you so much to all of our champions. And just to reiterate, the goal of the Anne Klibanski Visiting Lecture Series is to catalyze and foster collaborations across national and international institutions. So next, I would just like to show you some of the institutions that we've collaborated with through the years. And highlighted in yellow right there is Weill Cornell Medicine logo to represent Dr. Watanabe. So now I will pass the microphone to Dr. Joanne Chu to introduce you to today's speaker. So thank you so much.
Thank you. It's my pleasure to introduce Dr. Watanabe. She is a general pediatric cardiologist at Weill Cornell Medicine. She got her BS and MS in cellular and molecular biology with a minor in French literature from Johns Hopkins University in Baltimore. She then received her MD from Weill Cornell Medical College, completed her residency in pediatrics at New York Presbyterian Weill Cornell Medical Center, and she completed her fellowship in pediatric cardiology at New York Presbyterian Columbia University Medical Center and Weill Cornell Medicine. She's the Associate Program Director for the Cornell campus of the Pediatric Cardiology Fellowship Program, and her research interests include topics in preventive pediatric cardiology. We're excited to hear her talk today. Thank you.
Good afternoon. Thank you to Dr. Chu for the introduction and to the visiting lectureship for your invitation for me to speak today. My name is Hanano Watanabe. I'm thankful for the opportunity to be able to spend the next hour with you. I'm looking forward to touching upon some topics that you may find interesting, and hopefully you will find it to be relevant to your daily clinical practice. As mentioned, I have no disclosures to make. We're going to be touching upon 3 vastly different but interrelated topics today. Here's a hint. They're all things that we may come into contact daily. Here's the first topic, and let's start with a riddle. In 2023, approximately 2 million middle and high schoolers reported usage. What am I? Yes, you might have guessed it, tobacco products. The National Youth Tobacco Survey puts out an annual report. In 2023, 10% of middle and high schoolers reported current tobacco product use at a time of the survey. Although compared to 2022 to 2023, the current e-cigarette use among high school students declined, e-cigarettes remain the most commonly used form of tobacco products among these youths. Among those who use it, daily use was reported by 25%, and most, close to 90% of the respondents, use flavored e-cigarettes. As you may have seen in your patients, or walking around town, or in school settings, or in general, use of electronic cigarettes is on the rise. Here's a map of our neighborhood in the Upper East Side of New York City. This past weekend, my kid and I were browsing at a store in Times Square, and I look up inside the store to a youth stealth vaping or zero vaping, meaning they're discreetly vaping without creating any smoke. I have definitely inhaled some vape clouds on the sidewalks walking in Manhattan. And if you are in New York, at least in this borough, there is a smoke shop in every corner and street of our city. Here's an interactive map of active tobacco retailers put forth by the New York State Department of Health. And here's our small neighborhood in the Upper East Side of Yorkville. There is a public elementary school here and several private schools in the area, and all are surrounded by these smoke shops represented by the blue dots. Here's a zoomed out map to give you a sense of the prevalence of shops, smoke shops in the Upper West Side, Upper East Side, Midtown, and in Queens. It's quite staggering. This is a similar map I found on the Massachusetts Department of Health website. Interestingly, Massachusetts has a regulation in place to reduce the density of tobacco retailers in any given city or town to reduce the exposure of these products to young people, and thereby reducing the influence of the tobacco industry in their community. To my knowledge, I do not think there is a similar legislation in our city, and I'm curious to hear from the audience how this legislation may translate into real-world experiences. We know cigarettes are bad, and so do the youth. Based on the tobacco survey, there's only about 1% of them who use the traditional combustible tobacco products. We know the ingredients in real cigarettes. They're bad. Acetone, ammonia, arsenic, benzene, butane, lead, toluene. There are over 600 ingredients, 7,000 chemicals, and at least 69 known to cause cancer. Many, if not all, are toxic. The tobacco industry had an estimated market value of $867 billion in 2022 and a whopping $1,050 billion forecasted for 2030. This is to say that the marketing power and influence by the industry is undeniably strong and insidious. Despite the obvious that cigarettes are bad, that did not seem to translate into the notion that use of tobacco products in any form by use is unsafe. So why is this pediatric cardiologist talking about cigarettes and smoking? Well, it's because I see a handful of these patients for chest pain. There was a patient last week who I saw in consults who had 3 emergency room visits for chest pain, with the 4th one to us. This young person shared candidly about his smoking history: 10 blunts a day, 20 pulls a day. And for those who may not be familiar with the term, a pull refers to an inhalation from the e-cigarette. I even asked him, do you go to school? How do you even have time to smoke all of this? There was an adult cross-sectional study called Heart-E-Heart study, and in this study, they found that those who used electronic nicotine delivery systems, or ENDS products, to have a greater proportion of respondents who said yes to chest pain and to palpitations. And consider another vulnerable population, females of reproductive age. While statistics on vaping and pregnancy is limited, we best estimate this to be around 7 to 10% in the United States. And while understanding that this is at best underreported and not reflective of real-world data, since e-cigarettes are being commonly used in youth, it is reasonable to assume that there is increased consumption by women of reproductive age. Perception seems to drive e-cig use in pregnancy, with people thinking that it is less harmful than traditional tobacco. And the main purpose of these e-cigarettes is to deliver nicotine. While nicotine is the main substance at play, there is legitimate concern that the other components of an e-cigarette system may adversely affect fetal development. That is to say, potential health effects of the e-cigarette ingredients are unknown, and the flavoring that there is something meant to be eaten, not heated to a high temperature and subsequently inhaled. The US Surgeon General, in their report from 2016, states that the use of e-cigarettes is a fetal risk factor. A scientific statement by the American Heart Association has a section on acute effects of electronic nicotine delivery system product use during pregnancy, and they summarize the evidence of health consequences of using such products. Animal models show that electronic nicotine delivery system products can reduce placental and cord blood flow, cause growth restrictions in the fetus, and growth delay in the postnatal period. We know that nicotine exposure can lead to fetal growth deficits. Nicotine to a fetus can cause inflammation, pulmonary and cardiac dysfunction, and cognitive issues. Furthermore, as I mentioned before, the flavoring that makes the e-cigarettes very appealing are not meant to be heated and aerosolized. Its effect on the cardiopulmonary system as a superheated chemical is unknown. In conclusion, long-term cardiopulmonary health effects are unknown after maternal electronic nicotine delivery system use and warrants further investigation. This almost makes it look like we're in a corner bodega store, but no, these are the refill juices. These nicotine e-juice refills are colorful, provides familiarity, and are reminiscent of everyday products. It's very grammable, Gen X, Z, and Alpha friendly, and even this millennial's eyes are very attracted to these. A recent New York Times article showcased this popular vaping device. They're called Elf bars. They compare this device to ombre airport cases. Have you seen these in the streets of Boston? And these Elf bars can contain as much nicotine as 590 cigarettes, according to one estimate. And to quote this article, these products have maximalist aesthetics of Gen Z and Alpha, and you want to show it off. There's even a dedicated Instagram following with a hashtag #ElfBar. And moving on to our second topic, which also explores another toxic non-occupational exposure. Here's the second riddle. I am named one of the 10 major public health concerns by the World Health Organization. And I'm responsible for about 1 million lives lost due to exposure and account for 22 million years lost to disability and death worldwide. I'm responsible for 30% of the global burden of idiopathic intellectual disability and 5% of cardiovascular disease. I'll give you a minute to think about what I'm going to talk about next. If you have some guesses, I encourage you to type it in the chat box. Alcohol. Good guess. Tobacco. Is there any other guesses? Okay. Marijuana. Good guess too. Environmental pollution. Close. Here it is. I am lead. There are many known and unknown adverse effects of lead, and there's no safe normal level of lead. It crosses the placenta, and we know that fetal exposure affects brain and nerve development. And to complicate matters more, the temporal relationship, time to effect, is unknown. Health effects can surface later in life. Various issues such as hypertension, reproductive problems, cognitive issues, even developmental problems in the offspring are known to be caused by lead exposure. You may think that lead is a problem with old houses and paint products. Your patients live in paint chip-free homes, new construction, no lead anywhere in the house, no worries. Unfortunately, the global commerce and market have brought lead right onto our plate and into our pouches. Take these stories from Georgia and Bangladesh about spices, and you may have heard recently apple pouches. A team of Stanford researchers are on their way to eradicating lead poisoning in Bangladesh. They have discovered that turmeric root was often powdered with lead chromate to make it appear more vibrantly yellow, and are purposely adulterated to enhance its weight at the market. There's a similar story out of Georgia and Georgian spices. These two stories illustrate that lead poisoning happens both globally and permeates locally, and that we must remember that our patients can come from different parts of the world in this global era. Cultural beliefs, eating habits, food sources can have different impacts on their cardiovascular health. And here's the QR code to the Bangladesh story out of Stanford. It's a fantastic public health win story that you can read. A systematic review and meta-analysis from the British Medical Journal concluded that we have to acknowledge the real and harmful environmental toxic metal effects on cardiovascular risk beyond the rules of conventional behavior risk factors, such as lack of exercise, smoking, and diabetes, for cardiovascular disease. And the American Heart Association also acknowledges this. Lead exposure is a risk factor for various cardiac comorbidities, and at any given lead level, children are more susceptible to the harmful effects. The Georgian spice market story is further evidence that adulterated spice market could be a significant source of lead exposure. This is a traditional Georgian dish, khachapuri. It's very delicious. It's full of butter, salt, saturated fat with eggs and cheese. And on that note, we will transition to our last topic. This is a wheel of modifiable risk factors to optimize cardiovascular health. Life's Essential 8 is a concept put forth by the American Heart Association to define cardiovascular health. And this was an update to the concept of Life Simple 7 put forth in 2010. And we're going to end today with a practical update on the purple box, pediatric dyslipidemia. And in going through the other boxes, Life's Essential 8, it's a very useful diagram to share with patients and their families to visually represent all the modifiable portions of our everyday life to maximize our cardiovascular health, starting off with diet, exercise, blood glucose level, so diabetes and A1C, BMI, dyslipidemia, we're going to touch upon, blood pressure, no smoking. And this is the addition to the Life Simple 7, and they added sleep to this concept. Our jobs as a pediatrician is to empower youth with knowledge and tool and to keep their cardiovascular risk profile at bay throughout young childhood, early adulthood, and hopefully through the rest of their adulthood. And this is especially true for me as a cardiologist and for you as pediatricians, and as true as it can be for really anybody involved with children. Blood pressure is important, not getting diabetes is important, not smoking is important, nutrition is very important. I sometimes discuss with my patients, exercise is medicine and the best medicine. And sometimes the best medicine is no medicine. We know that subclinical atherosclerosis starts in childhood, and there are no symptoms of atherosclerosis in its mildest form. Think about that. There are no symptoms of atherosclerosis in its mildest form. Hence, prevention of atherosclerosis is by lowering LDL and diagnosing and treating those with the genetic predisposition for early atherosclerosis become very important. And these are the patients in whom diet and exercise alone may have a slight effect, but certainly not enough to change their biological clinical trajectory of atherosclerosis. And let's talk about the clinical landscape. How common is this problem? The prevalence of all forms of hyperlipidemia in obese children is about 40%. And we may often think that dyslipidemia is a problem with obesity. It's important to note that the rate of dyslipidemia in normal weight children and adolescents is 14.6%, close to 15%. It's not insignificant. Hyperlipidemia in children and adolescents may thus be one of the most prevalent risk factors for early atherosclerosis. And to add to this, another interesting statistics, the prevalence of familial hypercholesterolemia is 1 in 250 to 300 people. Think about your high school class. Think about your college class. Think about the friend circle you may know, and compare that number to the statistics. Familial hypercholesterolemia is an inherited condition where there are mutations in genes such as LDL receptor genes, apolipoprotein B genes, and PCSK9 genes. And these are the genes that are implicated in how our body regulates and removes cholesterol from the blood. Here are some comprehensive reviews and very good reads on the topic if you're interested in reading more about this. It's a very, very nice summary talking about childhood cardiovascular risk factors and adult cardiovascular events, as well as risk assessment and management for general pediatricians. And in regards to screening for pediatric dyslipidemia, there has been a universal lipid screening practice in place since 2011. This practice has been endorsed by most societies, and there was an update in regards to this practice most recently, and still the endorsement stays the same. In general pediatrics, preventive universal lipid screening starts between the ages of 9 to 11. It can be done earlier if there are certain risk factors present in the clinical history or the family history. And the screening is again repeated after age 17. And as I mentioned before, atherosclerosis is clinically silent until it's not. And really, there is no optimal way to screen based on history and exam and family history when it comes to diagnosing and finding those patients with true genetic predisposition for dyslipidemia and early clinical risk for atherosclerosis. Hence, universal screening is performed. As pediatricians and subspecialists, we must also remember that our patients with complex medical conditions, as listed in this table, deserve special attention when it comes to optimizing their cardiovascular health profile. And this table is from the same paper that provides an algorithm for different risk categories for patients in regards to their cardiovascular health parameter goals. In other words, the high risk category have more aggressive thresholds, tighter BMI control, quicker time to initiate pharmacotherapy for blood pressure and or limits, and they have lower LDL targets. And finally, here's the table for normal lipid values in pediatrics. These numbers are based on national data from a large population that was sampled in the 1970s to 80s, and additional data gets incorporated from time to time. The fact that we set these ranges and parameters based on population distribution is very interesting to think about. And finally, the interpretation of lipid levels can be challenging for anybody, and the study that recently came out majorly highlights a problem worth thinking about. This study reports that erroneous reference ranges used in some independent laboratories highlights missed opportunities for diagnosis and treatment of these patients with dyslipidemia. And this is a very interesting study, and we're thinking about it more for sure. So that concludes our quick tour of 3 seemingly unrelated topics, but what ties them all together is that they are all potential everyday exposures that cumulatively may have significant health effects. And the exact science behind it all is yet to come. Nonetheless, there is compelling epidemiological signal that's worth investigating. And in closing, I will leave you with the current innovations that is happening in the worlds of congenital cardiac surgery and pediatric heart transplant, and the amazing care options that will undoubtedly become life-saving options for our patients.
This is one of the most awesome and coolest operations I've ever been a part of. So we have done the first domino heart valve transplantation. A domino transplant is when one patient is both the recipient of a transplant and then also becomes the donor for another transplant. We can use part of that heart that's still working well and put it into someone else to save another life, creating a living heart donor, which is very unique.
On May 10th, Mia received a heart transplant, and they presented an opportunity to give the valves to another baby in order to save another child's life.
We can't thank them enough. What they did for us.
So Mia came to our hospital back in October. She was in acute heart failure and very, very sick. Mia has cardiomyopathy, disease of the heart muscle itself that causes the patient to go into heart failure. We listed her for heart transplant as there were no other options for her at that time. Brooklyn had a type of congenital heart disease called truncus arteriosus. Instead of having 2 outflow valves from the heart, a child is born with only 1 outflow valve. The left ventricle was starting to fail.
There are different options to replace heart valve in children. None of these options actually are living options. So they do not grow with the children and they do not self-repair.
The standard of care for infants requires multiple cardiac surgeries. And at the end, they're usually not left with a fully functioning normal valve. Timing was actually very serendipitous. I had received a donor offer for Mia. That was about 2 in the morning. The next morning, we reviewed Brooklyn's case. I said, well, I'm doing a heart transplant tonight, and Mia's valves actually work perfectly. Maybe we should do this as a domino. The family really did not hesitate to offer Mia's valve to another child. We went to the operating room at the same time. He would need to be ready to put in the valves by the time that I explanted the valves. Everyone was on board and everyone put their all into making sure this would happen, from the physicians to the nurses, everybody.
It was a long 9 hours, but the relief afterwards was just incredible.
Brooklyn's parents cried, and actually I cried as well. Kind of magical moment. This kind of procedure can be a game changer in our field because it provides living tissues which can grow and self-repair. That will avoid multiple open heart surgery and reoperations down the road.
I'm so happy.
Thank you so much.
Words can explain how much we appreciate you.
It still doesn't feel
Yeah,
real.
going home is going to be one of the biggest moments in our life.
We're going home this week is incredible. Just feels good to be able to start living our lives.
From the surgeons only to the people who stock the equipment that the nurses need. Fantastic.
Yeah,
It's top of the line.
we're just so grateful that not only is Mia a recipient of a beautiful gift, but she also had the opportunity to be a donor. Thank you so much for your attention. This concludes our talk. I know that we have some time left over, but I'm looking forward to hearing your thoughts and comments of any of the topics that we discussed today. Thank you.
Thank you, Dr. Watanabe. I wanted to open it up for any questions, comments, or thoughts from the talk. If you would like, you can also write this into the chat. Dr. Angela Lynn wrote a comment there. I find myself thinking about the third set of parents, the donor heart. Angela, I had that thought as well.
Absolutely. Full disclosure, I am not a heart transplant person. However, taking care of some of these patients during fellowship, it was always bittersweet to go into a patient's room who's been waiting on a VAD for months and telling them that they have a heart. It's always a bittersweet moment, and this is the best gift that anyone in this type of situation can ever give. So selfless and so giving and so generous.
Great. Dr. Lorraine Schratz has a question.
Hi, thank you for an elegant talk, and thank you for joining us today. Sorry that I'm not on video. If you saw me, I'd have a Santa hat on because there's a Christmas party where I am. So anyhow, that's not my question. So my question is related to your whole talk. So when we have fellows come to train in pediatric cardiology, most of the time they're most excited by what you showed at the end of your talk, all of the, new technologies, surgeries, interventions, and procedures, and not usually as interested in preventive cardiology, which incidentally is only a small section of the American Board of Pediatrics content guidelines. It's like part of a 7% section. So obviously our boards don't really emphasize preventive cardiology either. And yet it impacts all pediatric patients, and those kids we're working so hard to save with our transplants and our interventional procedures. So I'm just curious if you have any thoughts about how we can help our colleagues and trainees be excited to learn and actually at least touch upon preventive topics when they see patients.
Yes,
I know it's a hard one. Thanks.
absolutely. Thank you so much for pointing that out. That happens to be one of my favorite topics of discussion. As the associate program director for the fellowship program, all my fellows know that I am the cardiologist, the oddball cardiologist who enjoys talking about preventive cardiology, who likes to ask about blood pressure parameters, who likes to ask about lipid screening guidelines, and who likes to think about patients when they're 30, 40, 50. Because what I tell them often is that, we are surgeons and our cardiologists, our interventionalists, all our cardiac specialists, as well as the pediatricians, as well as all the pediatric subspecialists who are providing excellent care to these very complex, fragile kiddos. We can get them home, we can get them out of the hospital, we can do really, really fantastic surgery, but what happens to them at 20 years down the road, 30 years down the road? I try to instill in them that type of lens, and in doing so, I think it brings them to see it from my perspective a little bit more, from a long-term perspective. And yes, the basic things, talking about going back to the 8 components of the life's essential 8, each of the components are very important. Establishing taste buds in the early childhood with dietary choices, that's very important, because I think it's all subconscious, and it's going to play a role when they start making those decisions about what to put in their bodies and how to take care of their bodies. I think establishing good habits during childhood is very, very important. And to me, as a general pediatric cardiology, I don't do anything fancy such as operate or do interventions, but that type of thought process is what I think I could share, instill in my patients, and if the patients are still young, to at least instill in the parents that type of thought process and mindsetting. So much of our counseling will focus on that, and I'm very fortunate enough to be involved in education of trainees at various levels. So even from the medical student level to the residents and the fellows, I'm very fortunate to have an audience who at least, it shows me that they're interested in hearing what I have to say. So I'm very thankful for that. And thank you for that question and for bringing up this topic.
I had a question while we're waiting for other comments or chats, but your first 2 topics helped me realize that there's a component of the cardiology visit that seems very similar to an adolescent visit. And I don't tend to ask parents to step out routinely for those kinds of questions. I'm not sure I would even have the terminology or the language or, you know, the slang to know how to ask these things. How do you practice, and do you incorporate this routinely in your teenager chest pain visits, or what do you recommend that we as cardiologists should do?
That's a very interesting question. In terms of these chest pain teenagers with vaping, cannabinoid, edible ingestion, maybe I am a magnet, but I've had a couple of patients when I initially started practicing Brooklyn. I've had teenagers who come in with real chest pain, EKG changes that were transient, and it would go back to normal after they have ingested unknown amounts of THC, cannabinoid containing chocolates. And of course, these things are all unregulated. So they have been very forthcoming, at least with me, in terms of disclosing with what they have eaten or inhaled. Perhaps that may be due to partly their fear of what may be happening to their body, because you know, these patients, they tend to have some troponin leaks, and I think the chest pain is real. As we know, THC, marijuana can cause coronary vasoconstriction, much like nicotine can cause coronary vasoconstriction. And at least in the adults, the framework of thinking is that if they have stable coronary artery disease, ingestion of THC or smoking marijuana can push them over and have NSTEMI. So I think it has something to do with transient coronary vasospasms, and they're really scared from the severity of their symptoms that they end up telling me, disclosing everything. In regards to the most recent patient who I saw as a consult last week, he was very, very forthcoming as well. His father was actually in the room, and this was a shared room. He told me that he vapes and smokes blunt a lot, and you know, I knew that from the chart. First, what I did was a standard, you know, I asked the parents to leave. I tell them that this is standard for me to discuss with the teenagers, have one-on-one time and without the parents, and that this is very standard. So I think mentioning that this is a standard procedure, it's a protocol, and this is what we just do for everybody. We'll bring you back in once we are done with this portion. We will invite you back in, and giving them a heads up of how many minutes they might be out of the room might really help them and understand why we're doing this. And most of the time, the parents or the caregivers, the adult caregivers, have been very understanding of this. I don't routinely do it with every teenager visit for chest pain. However, inpatient consults tend to provide that opportunity a little bit more, because the parents might be away, or they might have stepped out to go to the bathroom. So definitely the inpatient setting confers more opportunities for making this very easy. In terms of outpatient settings, there are teenagers who do ask me if vaping is okay. So I use that as a point of entry of the conversation about, okay, so, you know, let's set the story. Let's understand what is going on. The teenagers often find me at a moment where they're not back in the room with the parents to ask me these. So it allows me to, after getting the initial history from both the family and the patient, to let them know, again, this is standard protocol. I'm going to ask you to step out of the room. I'm going to have a private conversation with your child, and I will invite you back in when we're done. So that's I really rely on the patient signal, and I think they want to tell somebody, but they really can't, and especially if they're there for chest pain, they're worried what's happening to the heart. Oh, is it the vaping? And I think it makes it easier for them to ask me as a cardiologist, and I see that as a unique opportunity for education and sharing the mental model about these products.
There was a related question in the chat from Angela Lynn asking about another form of tobacco, which is cigars. And she says, no longer a habit of old gentlemen in a smoky bar. It's now considered cool among millennials. So what are are there special risks for these cigars compared to other forms of nicotine?
That is very interesting. I need to look up the exact amount of nicotine in each cigar. I have seen cigar shops. They're much like fountain pen shops. I feel like there's so many variety of them, so many different types. So I can't comment on cigars. Interesting to hear about that. I'll look into this.
I happen to know because I'm related to a 30-year-old who's he and his friends, it's like a lifestyle thing. It's cool to do. But he was honest enough to admit to me, do you think this is dangerous, Mom? So I'm asking you as an expert.
That's very interesting. I am not an expert in all of the tobacco products. So that's something that I will look up. I'm a millennial, and this is something that I have to ask my circle of friends, but I think I will be biased in this case, but I will ask around.
Hi, I just wanted to add a comment as well regarding having parents stepping out of the room for part of the visit. Sometimes what I do in primary care is also then give a chance for the parents to speak with me without their child present. Because sometimes there can be a lot of maybe back and forth on the dynamics in the family, but also in terms of getting family history, or also getting a chance to obtain any family history that they might not be able to share with their child present. So sometimes being able to say, oh, I meet with everyone a little bit alone, one-on-one during their time in clinic.
Thank you so much for pointing that out. That reminds me of a couple of, I think New York City parents tend to be very not shy about asking us what they want. So I definitely have had parents, I need to talk to you without the kid in the room. Is that okay? So yes, they make it very easy for me when it's very obvious what they want me to do. I've definitely had those.
There is one comment in the chat from Dr. Tantenko. One thing that I find very challenging, how do you effectively dissuade our teenagers from vaping and smoking? Any techniques, any follow-up strategy that you find works for you?
That is a very interesting question. And I can only speak from my experience with some of the teenagers who come to me for chest pain. First of all, I think they are already very wary when they know that they're at the cardiologist's office and that something may be going on with their heart. So perhaps that becomes a therapeutic visit from that standpoint. So, cardiology referral, welcome. And when I do point out that there are unknown effects meaning that there is no it's not safe. I think they need to hear that. I think perception plays a big role in their generation's thought processes, and just because there is no data doesn't mean that it's safe is something that I see a light bulb turn on when I break it down for them. I do share the story that nicotine as well as cannabinoids, marijuana, can cause real effects of vasoconstriction, your tiny blood vessels that's feeding oxygen and nutrients to your heart, the pumping machine, also to the deep ends of your brain. They're very sensitive to these chemicals and can cause some tightening to it and cause blood not to flow there. And when I explain it in very elemental language, I see their eyes widen and their pupils kind of get smaller. And I think it really, I don't mean to scare them. I mean to objectively tell them known facts and share with them, empower them with the knowledge. And ultimately I tell them it's your body, it's your heart, it's your brain. I want you to have all of these working and intact when you're 30 years old, 40 years old, 50 years old. I understand that, young people, I myself was one of them many decades ago, but it's hard to think about what's 20 years down the road. It's really hard to envision that. What I try to do is I try to share that perspective with them. I try to talk through with them, what may be happening in your life. I certainly don't want you to have diabetes or hypertension or, taking medications or going to the hospital and getting all these IVs in your body, making holes. And when I break it down to them like that, I think it does help with with me connecting with them. Of course, this is not coming anywhere from my part of scaring them, of fear-based. It's just telling them the reality and telling them what I hope for. What I hope for them is a healthy 20 years, 30 years outlook, and that they grow into healthy old people with strong cores and strong hips.
Thank you, Dr. Watanabe. Any other questions or thoughts from the group?
Hi, Joanne. This is Angela again. Dr. Watanabe, I think we would agree that part of medical school wasn't learning things like marketing, communication, but as modern doctors, we have to do this. One of my patients said to me, I run a clinic for Myhre syndrome, you need to be on TikTok. Now, there's no way I'm going to be on TikTok. It's not dignified, it's not professional, and yet that's what people are watching. So is part of it our responsibility? You're the millennial, you tell us. You know, should there be a modern day Marlboro Man? And I hope you're old enough to remember that, but those were really effective and kind of scary.
Yeah, I think that's a great point. I wish I had more instructions on communication, even you know, learning about different personality traits, learning about different learning habits. I think there's so much more to medicine than just clinical knowledge and clinical practice. And I think the effort is there. When I saw the New York Times article, it was very eye-opening because I definitely have seen these on the streets in New York, and it's so eye-catching. And imagine a toddler grabbing these, and it's kind of like the Tide Pods when they first came out with the colorful Tide Pods, and there were ingestions. And of course, look at the juice boxes that are the nicotine fillers. I really hadn't really thought about these until I peeked into the smoke shops and really became aware of what's around. And this is what's surrounding our children. And again, I'm a pediatric cardiologist, but I think these issues should be and transcends every specialty, even the surgeons, because it really matters to everybody. It matters to our children. It matters to the unborn fetus. It's their world. And my perspective is to learn their language. You know, I know I can't acknowledge the fact that I am different from them, but I am. And so learning their language, learning their body, their world lens, helps me understand perhaps how to, you know, get them to change behaviors. Behavior changing is very difficult. They're influenced by their friends, their peers, schools, their world. So my approach is to understand them a little bit more. I'm not very active on Instagram at all. I see my fellows very active on Instagram, and I'm only a couple of years ahead of them, but the world has changed so much and is continuing to change. So I got Instagram. I will look things up. I will Google things, and Google is just wonderful. I can learn so much from their world, but what really strikes me is that, you know, when I'm on York Avenue, I see the young children going in and out of the elementary schools and all the schools around us, and you see the teenagers and all the smoke shops around them, and just that vast divide between the two generations, and the habits they may be displaying and affecting, you know, the younger children's minds. And that's what I think motivates to be involved in this topic and really share about and talk about these topics.
I have a question. You talked a lot about nicotine and cannabis, but something that you haven't talked about is alcohol, which still continues to be the most commonly used substance among this age group. What can you say about alcohol use and how that affects outcomes?
That is a topic that I need to learn more about in order to answer. But certainly alcohol is definitely prevalent. Just from my point of view, most of the teenagers who come to me, they disclose that, you know, alcohol affects their whole, it affects their mind. They lose control of their bodies, so they don't like that aspect of it. So therefore they prefer vaping more because they get that hit, they get that nicotine high, but they don't necessarily lose autonomy or, you know, black out. So that's just some points that I've heard from my patients in terms of why they prefer one substance over another. But that's definitely worth looking into alcohol use. Yes, I agree with you. It's very prevalent.
So it looks like there are no additional questions. This was a fantastic talk. I think everyone in the chat agreed that they learned a lot and it was a terrific talk.
Well, thank you so much. I really appreciate the interaction, everybody sharing their thoughts and input. And this is very lovely. Thank you so much for inviting me.
Thank you for coming.
Yeah, thank you so much.